Good afternoon, everyone. Welcome to the BCCC. My name is David Speakman. I'm the Chief Medical Officer here at epidemics. So welcome to you all. Just like to start by acknowledging the traditional owners of the land where this event is taking place, the Wurundjeri people of the Kulin Nation, and pay respect to their elders past, present and yet to come. It's my great pleasure to introduce Ian Barr to you to talk to us a bit about influenza today. Obviously, the start of the influenza season, which we hope will be short and contracted this year. Ian's the Deputy Director at the WHO Collaborating Centre for Research on Influenza in Melbourne, across the road at the Doherty. There's only 4 of those centres in the world, so we're very lucky to have one based here in Melbourne. They look at the regional surveillance and analysis of influenza, including gene sequencing, antigenic analysis, antiviral resistance testing. So really cover the whole gamut, I think, of influenza for us. Ian's been in this field for 35 years and written over 200 papers on this type of stuff. So we're lucky to have someone of such experience and wisdom to talk to us. He's going to take us really from influenza then and now. So maybe right back to the Spanish flu, maybe even before that, and then hopefully finish up by telling us how we should be looking after both ourselves and our patients in 2018. So I hope you'll welcome Ian Barr.
Okay, thank you, David, and thank you to Susan Harper for inviting me to speak to you today. It's a pleasure that I don't get very often over here, but hopefully by the end of this talk, you'll realise the importance of influenza, not only to you, but to your patients and to your family, and what you can do to give them the best chance of getting through this coming season, which is about to start. So the topic is influenza now and then, and I'll take you through a few different aspects of that. I just want to acknowledge that our centre is heavily supported by the Australian government. So I'm going to go through a few basics on influenza. I know most of you in the audience will probably know all of this, but there'll be a few who don't. I'll give you a little bit of background on our centre. I will go back to the 1918-19 Spanish influenza. It's 100 years now since that pandemic occurred, and it's always good to reflect on past events and to reflect a little bit whether we would do any better in this day and age than they did then. We've also had a recent pandemic. People have already forgotten about this one, but it was only in 2009, so I'll just hark back to that for a few minutes as well. Last year was a very big season in Australia, for most of Australia at least, and bigger or as big as the 2009 pandemic. And I'll just touch on what happened after it left here and went north, or did it. And I'll also spend a bit of time talking about how you can protect yourself and your patients and family against influenza, and a bold prediction for 2018. So influenza is often described as a single disease, but it's quite different than a single disease. There are 4 different types that we can determine in the laboratory: type A, B, C, and recently there's been another group called type D. Now these vary quite a lot in terms of the host that they infect and the effects following those infections. So type A is the one we hear a lot about, and these viruses are quite capable of infecting a number of different species. Their main host, or their central host, is wild water birds, but they can easily spread into chickens, poultry. They can also spread to horses and dogs, and they've even got into cats, bats, and whales and seals. So quite a mixture of viruses there that can end up in different hosts. Most of those are by accident. They're not meaning to infect these people, and of course man is exposed to a number of those viruses through those different animal sources, either directly or indirectly. Type B, we more or less have that type of influenza to ourselves. So there have been influenza B viruses isolated from seals, but that's not an ongoing infection, and it's not quite clear how the human-seal interaction occurs. But the main host there is man. Type C is another type of influenza, and that affects mainly children. So most children are exposed to type C influenza quite early in their lifetimes, and usually that's a self-limiting disease and doesn't cause a lot of morbidity and very little mortality. How that circulates around, again, is a little bit unknown, but there are certainly viruses which we can pick up in pigs and whether they transmit to bovine species or not is not clear either. But again, man is the main host for the type C viruses. Type D viruses have been recently described. They were a subset of the type C, but they're now got their own little subtype, and they're mainly confined to bovines and haven't been found in other species yet. So just a little basic on the influenza virus. So you can see there's an electron micrograph there. It's a small virus. It doesn't always look as nice as regular as this, but the schematic on the side shows a little bit more detail. So there's little protuberances on the outside of the electron micrograph. There are two different types of proteins, the hemagglutinin and the neuraminidase. So the hemagglutinin is involved in binding to cells of the respiratory system, and the neuraminidase is involved in clipping off those viruses when they're replicating. It has a segmented DNA, RNA genome, and you can see there that each one of those segments codes for a different protein. So in terms of nomenclature, sometimes we get a little caught up on nomenclature and people wondering what on earth these new viruses are. So I just thought I'd put this one in here, and it's a fairly simple system we have for naming influenza viruses. So I've told you about the types, and so we have A, B, C, or D, so that's the first part of the name. Then the place where it's isolated from, and that can be a city or a state or even a country. Then we have just a running number. Here's 411, so that's the 411th strain that was isolated in that year. The year 2002, self-explanatory. And the H3N2 part, this describes the hemagglutinin and the neuraminidase on the surface of those proteins. So that hopefully demystifies some of the names of these viruses. So they're human viruses, and if we have an animal virus, usually the species follows the type. So we have A, chicken, Lao, blah, blah, blah. And that way we can distinguish which animal source these viruses were from. So in terms of surveillance, the WHO has had a long-running system in place globally. And this just shows you a world map here with a lot of dots on here. So all of those bluish triangles are national influenza centres. So there's 143 of those in 113 countries. So there's 3 of those in Australia, 2 of those in New Zealand. And the red blobs on there in Melbourne, in Beijing, Tokyo, London and Atlanta are the WHO collaborating centres. So we're at the apex of those 143 national influenza centres. And this system was set up by WHO in 1952 and is the longest continually running surveillance system in their portfolio. So we've been around quite a long time as well. I didn't start in 1951, but others did at CSL, where Melbourne was designated as a regional influenza centre, not a collaborating centre. And that was about the same time as the whole system was set up by WHO. And then the centre was designated in 1992 as a WHO collaborating centre, and we were the 3rd, in fact, out of the currently 5 that are designated. In 2006, we had a bit of a shift. We moved from CSL to Vidral. We actually didn't move until 2008. 2009, we had the pandemic, so it was just in time. And then 2014, we moved across the road here to the Doherty Institute. We're on the 4th floor if anybody wants to come and see us. So what do we do? There's a whole list of things there that we do. Most of them are involved in surveillance, and as David said, we look at the characteristics of those viruses, their drug resistance, and we also do work in the area to provide training to support these national influenza centres. We also do a level of research. So that map shows you where we get our viruses from to analyse. Most of them come from Australia and New Zealand, but we also have good representation from Southeast Asia and get samples from Sri Lanka, South Africa, and even further afield than that. So a few words on the 1918 Spanish influenza. Probably not many of you would be following what happened back then, but we had a bit of a delay, fortunately. The Spanish flu affected most of the Northern Hemisphere in 1918, and we didn't get it until 1919. And what we found was it was a variable severity in different states. So most of the mainland had a fairly severe episode, and in New South Wales alone there was 500,000 cases and 14,000 deaths. And it's a slightly different version than what we see currently with influenza. It targeted mainly the young, healthy group, 25 to 39-year-olds. And this put a real pressure on the health services at that stage. For example, in New South Wales, there were 25,000 admitted to hospital in this period, January to September, but there was only 2,000 beds available. So they had to make do with a lot of temporary hospital beds. And there are also strains on the whole system of the Federation, the Commonwealth and state rivalries about closing borders and whether people should be put into isolation, whether boats should be put into quarantine, and how this whole system operated. And really what happened in the end was most of the states went their own way and decided their own outcomes. But there was closure of public places and events. There were border isolation camps trying to keep the virus out of the states, which obviously didn't work. There was public reaction, which is somewhat hysteric. And you can see, as in this picture here, there was a lot of wearing of masks, people thinking this was going to help prevent infection. So this is what the epicurve looks like for New South Wales in 1919. And you can see there was this sort of pre-wave of influenza in the March to May period, and then the main wave of virus infection occurred between June and August. So not dissimilar to the 2009 epicurve. You can see there was more deaths in the metropolitan area than the country areas, which is not surprising. Here's a picture from Peter Curzon's collection here. This is the crew getting ready to transport patients. This is in New South Wales, in Sydney, Riley Street. And I spoke earlier about the different type of curve or different type of age groups that were affected by these this pandemic virus, the Spanish influenza. And you can see here that the 1891 shows the typical U curve where you have mainly infections in the younger and elderly. And in the 1919, you can see this so-called W curve here, where it was mainly the younger people who were affected, the 25 to 39-year-old age group. And this is where a lot of them ended up. This is the exhibition buildings here in Melbourne, which was used as a temporary hospital. So 1918-19 was the biggest pandemic that we have in recorded history, but there's been a number of pandemics prior to that event. You can see here, I've got the arrow here in 1918-19, and this is a paper by Morrins and Taubenberger who've gone back through historical records and have calculated something like 10 pandemics have occurred before the 1918-19 episode. And you can see there's variable gaps from very short periods of 5 years to a period of 149 years where there was no recorded pandemics. But you can see there is a certain frequency there, somewhere between 20, 30 or 40 years between pandemics. And there's also been pandemics after the 1918-19. So some people would count 3, some people would count 4 since the 1918-19 Spanish flu. The Spanish flu has been credited with 40 to 50 million deaths. Nobody really knows the exact answer. Many of the Asian areas, India and the subcontinent, they have no idea how many people died there. And that was caused by a H1N1 virus. That had a case fatality rate of something like 2 to 3%. So since then, the 1957 was called the Asian flu for something different, a much lesser impact, 1 to 4 million deaths. This is in the period when we have antibiotics, which is probably the single major difference between some of these earlier pandemics and these later pandemics. That was caused by H2N2 virus, had a much lower case fatality rate. 1968, we also had the H3N2 virus, again 1 to 4 million deaths and a low case fatality rate. And the most recent pandemic was in 2009 with 0.1 million deaths and case fatality rate very low, caused by a swine H1N1. There's also another one that crept in here in 1977, and that was a re-emergence of the H1N1 virus, which had gone out of existence back in 1957. And this is put down to the Chinese groups working with live attenuated viruses that got out of hand and spread around the world very quickly. So what happens after a pandemic? This is what happens. So most of the times, such as in the 1918 situation, you have that virus runs its course, and it was more or less wiped out by 1957 with the introduction of the H2N2 virus, shown in blue. Okay, so shown in blue here. So after that period, we had the H3N2 come in, and again, the H2N2 died off. And then this Chinese episode here, which I mentioned earlier, re-emergence of the H1N1, and that died off in 2009 when the pandemic that originated from swine arrived. And I should mention here that down the bottom here, we have influenza B, which has been with us all through this period of mixing and matching of influenza A viruses. So the 2009 pandemic, just to remind you all, it was the first pandemic for some 41 years, or 32 years if you take the 1977 virus into account. The first US cases occurred in March 2009. In Mexico, probably somewhere in the period February to March 2009. The first Australian case was picked up in Brisbane by a woman returning from Los Angeles, but other importations occurred relatively quickly. So, in fact, Melbourne or Victoria was the virus hotspot for Australia. You can see that on this epicurve down here. This pinky colour here is the cases which were recorded in Victoria and soon spread to the other states of Australia. So that happened between the period of July and October, and was mainly young children who were affected and young adults. The median age of infection for that virus was 21 years. Had a high number of cases. In fact, most of the diagnostic labs stopped testing for influenza, and diagnosis was made just on clinical conditions. There was a modest death rate as recorded in our systems, which always underestimates the number of deaths, but that was recorded 191 with a median age of 48 years. The hospitalisation rates were high with a median age of 31 years, reflecting this younger age group again, and 13% of the people who are hospitalised end up in ICU with a median age of 40 years. ECMO was used for the first time in a pandemic as well, probably saved a number of people. So they're raw counts that I was giving you there. So there's been some modelling done by Lerner, Simonson and co, and this shows you what happened on a global basis with the 2009 pandemic according to them. So what they showed here is a world map here and the heat map showing the number of deaths per 100,000 people. And you can see that some hotspots certainly occurred in the under 65s in Mexico and in South America, and all ages. There was also other countries which came into play here as well, such as Canada and India, Pakistan. And many people have said that the 2009 pandemic was similar to the seasonal influenza. And when you look at this broken down here, this shows you the seasonal in blue and the pandemic in red. And you can see that the numbers are pretty similar, but what we did notice here was a reversal in what we normally see here. So the seasonal viruses here, it's mainly the over 65 are affected here, shown in the light blue here, whereas in the pandemic here, the over 65s were less represented here in the total number of cases that died from 2009. But some groups were overrepresented in this particular pandemic, and they were Indigenous people, pregnant women, and obese people. So we often get asked, and it's constantly on our mind, what's going to happen in the future? What's the future pandemic? It's a bit like crystal ball gazing, and probably about as informative, but we do go through the motions. So we don't know the source. We don't know whether it's coming from poultry, from pigs, from horses, from dogs, from wild birds, or even bats. We know that one of those sources of viruses, the H5N1 virus in poultry, has been widespread in Asia since 2003, and spread to many parts of the world recently. So the so-called H5NX, so that has a different number of neuraminidoses attached to it, has gone all around the world. But there's only been a small number of human cases, 18 cases, of which about 2/3 have been fatal in China. Recently, we've seen the H7N9 virus emerge in China in 2013, and there was a huge number of cases here in 2016, 17. But you probably can't even see it on the axes here. The latest group here, the 2017-18, the number of cases there has been reduced to a handful, mainly through poultry vaccination rather than human vaccination. This just shows you the H5N1 or NX distribution in red here globally over the last 12 months. So you can see Australia has avoided the H5N1 virus so far. So it's very difficult to estimate what's going to happen in the future. There's plenty of opportunities for interactions with humans in the poultry markets and live bird markets in Asia. There's pig fairs in the US, which are very popular, especially with kids. That's a source of infection there. And everybody loves their dog. And there's been a couple of viruses circulating in dogs in the US in the last 10 years. None of those have gone over to humans yet, unfortunately. So on to the 2017 situation. So this is, you might remember some of these headlines which were on the news every night and in the newspapers every single day about the 2017 influenza season being the worst on record. There was a lot of press coverage on all forms. There were deaths there from young people and mums. So this is the sort of thing that gets newspapers very excited. So it was a big year. This is a graph showing here the influenza-like illness for 2017. And you can see it's bigger than the previous 5 years and was quite extended. Sometimes that doesn't tell us everything. If we go to laboratory confirmed cases, this shows you here in red the 2017 cases, which were well above previous years. Part of that is due to increased testing, but it was certainly a big year regardless of increased testing. I said before there was a number of different types of influenza that circulate seasonally, and here this graph shows you the types of influenza that were circulating in the different states here. So red is influenza A, yellow is influenza H3, and probably can't see much orange there. Orange is H1 virus, and green is the blue virus. Green is the B virus. And you can see here that the viruses which circulated in the States were quite similar there, and were a mixture of mainly H3 viruses and B viruses. When you look at it on a state-by-state basis, all states were heavily affected, with the exception of Western Australia. We don't quite understand why that was the case, but Western Australia dodged a bullet and had a very low season compared to everybody else. And the other people that dodged the bullet were the New Zealanders. So they had a very, very low year as well, virtually non-existent by historical records. Hospitalisation is something which we're always interested in to give us an indication of the severity of the season. And you can see here in this top left curve here that influenza cases that were admitted to hospital were again record numbers in 2017, and mainly due to a mixture of H3 viruses and B viruses. We also record deaths, and this is a very simplistic way of recording deaths here. These are the numbers which are recorded to the National Notifiable system. And you can see in 2017 there was a 5 times increase in the number of deaths recorded. The median age was 85 years, and most of those cases were due to influenza A, presumably H3N2. This is a different way of looking at it here. So this is a curve which is generated to try and smooth out some of the bumpiness across the year in terms of deaths. This is just New South Wales data here. And you can see that there's bumps above that line, which is meant to represent the upper limit of natural variation in deaths over the season. And you can see there for 2017, things were well above the normal curve there, indicating a large number of deaths, again, generally in the elderly. So how did the vaccine perform last year? I'm sure most of you heard on the news that it didn't perform so well. This is data generated from our laboratory, looking at people who come into general practitioners and looking to see how well they were protected. So overall, in all ages here in the top number here, we recorded a vaccine effectiveness for medically attended people of around 33%. And you can see there that the figures for adults over 65, the number there was very low indeed. We can talk about reasons for that a little bit later. So what happened to the Aussie flu as it progressed around? Did it get out of Australia and go to the US or Europe? Certainly the US had a very similar season to what we did, and that's shown on the top panel there, and the red curve there is their influenza-like illness in 2017-18. They had a record year as well, and it was very similar to the pandemic year in 2009. Europe fared a little bit better. They had a mixture of B's and H3 viruses here. And this funny diagram here is meant to indicate a heat map. A heat map here of the different countries in Europe here. So red is high and going down the scale, orange, yellow, green in intensity. So they had a moderate year, but in the UK, that news article there on the right-hand side said it was the biggest year in 7 years for Europe as well. But probably ameliorated by the impact of having more influenza B virus, which should be better protected. So who's at risk from influenza? Well, everybody in this room and every age group is at risk from influenza. So you can see there in that graph there that some age groups are more overrepresented than others, but everybody is susceptible to influenza. In terms of hospitalisation, this is this standard U-curve that we see in most years. 1918-19 was the exception here, whereas most of the hospital admissions are for the under 5 and especially under 2s. And that tails off and then rises again for the elderly over 65 years. And most of the mortality for influenza infections is associated with 65-year-olds in most years. People think it's just an old person's disease, but here's some data from the US showing pediatric deaths. They have a slightly different definition of pediatric deaths here. Their idea of pediatrics is 0 to 18 here, but you can see every year here, there's 100 plus deaths. So what's that, 119 deaths of so far this year in pediatrics, and that will rise, no doubt, as time goes by. And more than half of these children who die from influenza have no other comorbidities that can be detected at time of death. So how do you protect yourself and others against influenza? Well, you can go to a desert island and camp out there for a number of months or years. That will work, but the trouble is when you come back or if somebody comes to visit you inadvertently, you could be easily infected. And some of these isolated populations do very poorly when that happens, such as in the Pacific, there were islands there where they had death rates of over 30% when the 1918-19 pandemic swept through. Vaccination we'll talk about. There are antivirals you can use, which we'll talk about a bit more. A lot of people put a lot of faith in vitamins or herbal remedies. When I go to Chemist Warehouse, there's just shelf after shelf of them. Let me tell you, there is no good evidence that any of those things do anything, not even vitamin C. So don't expect any miracles there. Masks have been used for hundreds of years now. There's a lot of contentious issues still around masks, whether they work, whether they don't work. Putting them on, taking them off, you're exposing yourself to a higher risk with that. I'd say the jury is still out on the real benefit of masks. And then you have the other question about what sort of mask, a surgical mask, a P2 mask. There are a lot of questions, how to dispose of them, cost, etc., etc. The basics, hand washing, cough etiquette, I think they've been proven. You can still pick up influenza from fomites on surfaces. Avoidance approach, so you could avoid public transport, maybe. You can avoid children, maybe. You can avoid winter. Well, let's go to Singapore. Here we are in Singapore. Most people don't realize that a lot of the tropical countries have influenza all year round. So they have quiet spots, they have hot spots, but anytime you look for influenza, you'll find it in a tropical country, especially one with a reasonably high population like Singapore, with 5 million people to share their viruses with. So, vaccines. All the vaccines are grown, that are available in Australia currently, are grown in eggs and are inactivated. They're based on the circulating viruses, or what we think will circulate when they're being determined. There's 2 types currently available: quadrivalent, which you heard from Chemist Warehouse, which have 4 components, 2 A's and 2 B components. There's a trivalent vaccine with 3 components, 2 A's and 1 B. The seasonal vaccines are updated every couple of years. We meet twice a year to decide on those strains, and our centre is one of the centres that decides on those strains. So if we get it wrong, we're the ones to blame. Only around a quarter of all Australians are vaccinated. That's over the whole population, but it's much higher in the over 65s. Your parents or grandparents are probably telling you it's about time they lined up at their GPs. So 75% of them or more are vaccinated each year, which is excellent. They're recommended to be given annually, and this is another point of conjecture whether or not these vaccines would be better given every couple of years or not. So there's a number of studies going on to address that. But in terms of changes in the virus, and the antibodies to the components in the vaccine do wane quite quickly. It's not like some of these other vaccines we get, such as tetanus, where you can get 10 years or more out of them. A common misconception is that it will give you the flu. The virus in all the vaccines available in Australia are dead, so you might get some slight reaction, but it's not the virus infecting you that gives you those reactions. Unfortunately, the current vaccine has rather modest protection when we get it right, and things are going well for us. It's around 60%, and you saw earlier last year's was only 33%. On the new front, or good front, we have new vaccines for the elderly and over 65 in Australia this year. So there'll be 2 vaccines available. There'll be an adjuvanted vaccine. So this has a component in there to improve the immune response to the virus components, and that's in the trivalent form. We have a high-dose vaccine, which has 4 times the amount of viral antigen as the current vaccine, or the standard vaccine, and that's a trivalent vaccine as well. So this just shows you some of the viruses which are in the vaccines by names. I don't expect you to recognize any of these, just giving ourselves a bit of a plug here. The ones in red are viruses which we generated in our laboratory across the road there and are used throughout the world for influenza vaccines. So who should get influenza vaccine? This is the list from NHMRC. So clearly the major targets are persons over 65 years of age, along with the pneumococcal vaccine. Both are free vaccines to those people. There's a long list here of people who are at risk of increased complications with influenza vaccine. These are generally free. Pregnant women is the #1 risk group identified by the WHO powers to be. But there's also many other groups here: persons with cardiac disease, Down syndrome, obesity, chronic respiratory disease, and important for the group here at VCCC, immunocompromised individuals are highly susceptible to influenza and require special treatment, and vaccination is recommended, and also should be considered for the use of prophylactic antivirals as well, which I'll come to in a minute. The good news is that children under 5 years of age have been added to the list of free vaccinations in Victoria, New South Wales, Queensland, and WA, so there's a few states still holding out, but hopefully they will come on board soon. And there's residents of long-term care facilities, people who are working with these immunocompromised people, healthcare workers, staff in nursing homes, staff working with children as well. They're all generally free. Travellers is another one. So the old times, you never used to be able to get vaccine outside of up till about October. Now you'll be able to get it through till February if you need it. But it is getting complicated, and this is just a chart put out by the South Australian Department of Health here, showing which vaccines which are currently available in Australia should be given to the different age groups. And you can see there that the GPs will need to be checking these charts to see which ones are recommended, especially in the onslaught of Chemist Warehouse and their push to get everybody vaccinated as quickly as possible. And New South Wales has taken another little step forward in terms of healthcare workers here. And so a few weeks ago, last week, they have mandated flu jabs for New South Wales health workers. And their definition of health workers that have to be done now are staff, medical staff, nurses, doctors, and allied health staff. So that takes in just about everybody, I suspect. In Victoria, we have a vaccination rate in healthcare workers of around 80%. That's not the same at every hospital. I don't know what it is here at VCCC or Peter Mac. I think Royal Melbourne was around 85% last year as well. So some centres are doing well, others not doing quite so well. I mentioned antivirals, and antivirals are another adjunct used against influenza. And there's a couple of drugs out there which are effective. Zanamivir or Relenza is its trade name, and also Tamivir or Tamiflu are both effective if used within 48 hours. One is an inhaler and the other one is an oral form. The good news is these drugs used to be quite expensive, around $50, $55 a course. They are now both off patent, So hopefully we'll have some generics available, which will be cheaper. Availability is still an issue because you still need a GP script to get those drugs. In New Zealand, you can buy them over the counter at your local pharmacy during the flu season. So maybe in the future we'll have something similar here in Australia. New drugs are coming. These bottom two drugs are available in Japan and Korea. So hopefully some of these might make their way into the Australian market in the next few years. The one on the right there is a very effective drug in clinical tests today. So in summary, influenza is monitored by WHO globally throughout the GISRIS system, and Melbourne has one of the 5 global reference centres here at the Doherty Institute across the road. We have a number of different viruses which infect man, influenza A, B, C, and then there's different subtypes and lineages to go with that to make it even more complicated. Pandemics occur sporadically on average every 20 plus years over the last 100 years. The 1918 pandemic was the worst recorded. Most recent pandemic, 2009, was mild. We don't know what the next one is. I don't think we'll ever see anything as bad as 1918 with the use of antibiotics now and improved healthcare. But they still could be worse than 2009. Epidemics occur every year, but they're quite variable in intensity and severity, and we still don't know how to predict which years are going to be more severe or intense going forward. 2017 was probably the worst season we've seen in living memory in recent decades, at least, but not in WA and New Zealand. So maybe we all need to move to New Zealand. What happens in Australia and the Southern Hemisphere doesn't always dictate what happens in the Northern Hemisphere. We did see differences between Europe and the USA, for example, this year. Vaccination is still the best form of protection if you want to give yourself the best chance of fighting influenza infections. Vaccination is recommended for healthcare workers by NHMRC, and as I mentioned, it's now mandatory in New South Wales hospitals in this coming season, 2018. New vaccines for the elderly will be available for the first time this year. They've been available in Europe and the US for many years. Other vaccines are still available in other countries and new ones that are under development, including the so-called universal vaccines, but these are likely to be many years away before becoming available, if ever. Antivirals, the Tamiflu and Relenza, are things to consider. They can relieve symptoms if taken within 48 hours of symptom onset, and hopefully new antivirals, which will be better than these drugs, will be available in the next few years. And I'm predicting a nice, quiet year for 2018, so that's my hope and wish. Thank you for your attention.
Thanks, that's fantastic. I don't know if you can predict the Melbourne Cup winner as well. That would be
Easy.
Have we take a couple of questions? Sure. Anyone?
Does the principle of herd immunity apply to viruses? And secondly, what makes it so intractable from a molecular level to get good vaccine?
First things first, herd immunity, yes, it will have an effect, but people predict you need at least 50 or 60% of people, including children, who are probably the biggest carrier of the virus. In the UK, they have introduced a system for vaccinating all primary school children, and that's had some pretty dramatic effects. So I think you certainly can find evidence for herd immunity and having an effect there. At 25%, you're very unlikely to get much advantage in herd immunity. So we've got a long way to go, or we take the UK approach and try and hit the children, which is what a number of states are now trying to introduce, but how popular it will be remains to be seen. The UK are using a live attenuated vaccine, whereas we're using an activated vaccine. On a molecular level, the virus does change and changes quite often, especially the influenza A viruses. The H3 is the main culprit. The main issue we think at this stage is the adaptation of the virus from what we have circulating in us to grow in eggs. So when we're trying to grow these viruses in eggs, they're no longer avian type viruses, they're more mammalian adapted. So they have to undergo some changes there, and often these changes are changes which are not good changes in terms of the immunity which they produce. So we get good responses to some of those egg components or egg changes, not so much to the ones we would like to have to protect us better against what's circulating. So the viruses, on one hand, always jump ahead of us, maybe not too far, but sometimes it does jump, and because vaccines have to be produced 6 to 9 months ahead of time, a lot can happen with the virus in 6 to 9 months, and the egg adaptations is a major issue currently.
Other questions?
A question that I received from patients from time to time is about the timing of their vaccination, especially in relation to the cycle of chemo, and I'm sure they have it before they go into chemo and how long after they come to chemo, or does it make some of that virus?
Well, I'm not a clinician, so I shouldn't really be commenting on these things, but you know, we've done quite a lot of work with the immunocompromised group there, and certainly, you know, before they start to have a good functioning immune response, you get pretty poor responses to the vaccination. So I think you have to wait until you have at least a level of functioning immune response there before you give the vaccination. You know, we're talking about now maybe using some of these other newer vaccines, the high-dose vaccines. They might do better. There is some evidence for that with the immunocompromised group there. Look, I think, you know, you really just have to be guided on the seasonality. So clearly, you know, if there's a season coming up, you want to try and protect the person over that period of time. And you just have to match as well as you can to try and get a period where there's an immune system that will be able to respond to the vaccine. In terms of bad reactions, it's very unlikely you're going to get much of a poor reaction with the inactivated vaccines. The live ones, that's another story.
The other little fire now. I just go.
Pneumococcal vaccine.
Mm-hmm.
Should that be given every year or what?
No, the current recommendations is a single dose of the pneumococcal vaccine, and there was a standard out there to be revaccinated after 5 years. But there's been some pretty bad reactivity after 5 years when they've reboosted. So currently there's no recommendation for reboosting of the pneumococcal vaccine for the elderly. It's just a 1 dose at 65 or older.
Thank you so much. You mentioned a few different policy perspectives in the UK, etc. From a public health perspective, we know that there's some evidence that social inequality can reduce people's access to vaccines, but also possibly impact the outcomes. We've got a few elections coming up this year. Is there one kind of major policy or that you would like to see done that could improve the situation for influenza in Australia?
Well, look, I think access to these newer vaccines is a big step forward, and the government should be applauded for doing that. It's taken a long time for that to happen. These vaccines have been available in the US for a number of years. Clearly, the government has managed to get those in and registered and available in a record time. So, you know, I think that's a good step forward. I think the childhood vaccination thing is something which I think is worth pursuing, and the states are doing that by subterfuge. So I don't know whether the federal government could do a better job of that. Just because they're freely available doesn't mean to say they'll be taken up. Australia currently only vaccinates about 1 to 2% of its kids. So, you know, it's a very, very low starting point. So, you know, I think more promotion of vaccination would be welcome as well.
After the report of the number of deaths, what proportion of vaccinations are in
In the deaths, there'll be some who are vaccinated for sure, but generally, especially in the kids, most of them are unvaccinated. The elderly, they'll be vaccinated, and I can't give you an exact figure.
If a patient presents to you with flu-like symptoms, is there a recommendation that you swab the patient, await a flu swab result, and then commence antiviral, or commence antiviral immediately and await the swab result to come back? And second part, is there a rapid flu swab, or do we do viral PCR?
So I'm not a clinician, let me state that again, but you know, my recommendation would be if that person is an at-risk immunocompromised person, and they had flu-like symptoms and it was flu season, then I'd be going straight with antivirals. The antivirals have very low side effects, so you know, they're not going to do much harm. It's not so much like antibiotics where you can generate resistance. If they don't have the virus, you're not going to generate resistance, so you're not going to do any harm there. In terms of testing, yes, there are rapid test kits available. They have a sensitivity of around 80 to 90%. If you get the good one, if you get the bad one, it might be less than 80%. And they're not so good for the B viruses. PCR is the gold standard, but still takes, you know, the same day sort of turnaround. So it's a bit slow. unless you put through a special request, then you might be able to get something done quicker, but PCR is gold standard.
And how much would a PCR test cost?
If we do it, nothing. But I think they're about $20 to $50, depending who does them.
It costs $40 to treat the patient. Not that I'm promoting.
Yeah, look, I think certainly antivirals have been underutilised in Australia and the UK as well. You know, antivirals are certainly much more utilised in the US and Japan than they are here. In Japan, they have a rapid test kit, and if you prove positive on the rapid test, then they're straight onto antivirals. That's all sort of caught up with insurance there in the Japan situation.
The front end.
Have you seen any statistics to show that taking the flu injection causes memory loss?
That's the question is there any data to show that the flu vaccine might cause memory loss?
Yeah, look, you know, there are some things which always crop up with vaccinations, and I'm sure that there is something, probably somebody has studied that and found that in a small number of cases. Is it background? Is it true? It's certainly not one of the things which comes up as on the statistics. Guillain-Barré syndrome is something which comes up, but it's, you know, very, very low frequency, 1 in 200,000 sort of thing. So it's very low, and the incidence of Guillain-Barré following influenza illness is probably higher than for the vaccine. So, you know, I think those sort of minor side effects are very hard to track down and to be confident that it is something associated with. What there was with the 2009, with one of the vaccines, there was episodes of narcolepsy with one of the vaccine types. It was depending on your HLA type, so it affected the group in Scandinavia more there. So, you know, some of these things are connected. So, but with the standard vaccines which are now being given, nothing to my knowledge.
Just over the weekend, I think it was, on one of the morning shows, they were talking about there's an expert came in and said, don't have the vaccine too early before the season's actually kicked off. Can you maybe give some insight into why that was the case and whether we are at the cusp of the season or not?
Well, it's very rare that we have any major outbreaks, apart from pandemic, in March. So my recommendation would be not to get vaccinated yet. You know, normally June is when things start picking up. We may get into May, but very rarely. And the peak of the season is in fact usually September. So everybody thinks we're through winter and everything is good now, and yet August, September is usually the peak of influenza season, at least in the numbers. The antibody responses do wane relatively quickly to the influenza virus, the inactivated standard vaccine. So, you know, I think the community, the flu community, has been trying to push things back a little bit, but there's a bit of a conundrum there because the vaccine manufacturers either do or think they get some premium by getting in first. So they're out there pushing it, and Chemist Warehouse are out there pushing it to get people in because earlier is better, or money or something. But from our point of view, you know, we'd probably prefer to see an April, May type vaccination rather than March.
Can I just follow up with the benefit of the quadrivalent versus trivalent and the differences there? I mean, again, using Chemist Warehouse has the quad, but most of us will get access to the trivalent. So
well, that's not quite true. So the quadrivalent will be the standard vaccine which is available to the under 65-year-olds. That has the 2 B components. Most adults are not going to benefit much from that extra B component. It's really the kids who are going to benefit from that extra B component. And the trivalent for the elderly has only 1 B component, but again, it's probably not that important for the elderly. It's the A's which are more important than the B's.
So to be completely political then, if you were vaccinating healthcare workers in an establishment like this, a trivalent vaccine would actually be satisfactory. Fair?
In my opinion, unless they're immunocompromised, yes.
Thanks. Great. There's one more question up the back. I might just squeeze one more in.
You mentioned that last year New Zealand largely escaped the epidemic.
Is that in any way related to the fact that antivirals are over-counted?
They're not big users of antivirals either, so they're quite low users as well. I don't know how easy it is to get them. You still got to go there, present to the pharmacist, and have influenza like illness before they give them to you, and you still got to pay the $50. So I think that's a major issue. If they were more freely available or cheaper, they might have a better uptake. But they had similar viruses as what we had here. They have similar vaccination rates, so it's a little bit unknown why they have escaped. Maybe they're more spread out or something, I don't know.
Fantastic. I think we probably better stop now. I just want to thank, once again, stick that last slide up too, please. I want to thank Ian very much from the VCCC and also from Susan for a wonderful presentation, very interesting and thought-provoking.